Great. So, good morning, everyone. This is Dr. Munjal speaking from Medical MCQ for All. So, let's start with the excellent topic endocrinology. I tried my level best to make this very, very informative, and those who missed, they are really missing this class today. So, we're gonna discuss excellent points today, all high yield and all absolutely exam oriented, nothing here and there. Absolutely take home message with the tricky topics where we used to do mistakes and where we usually do not have the concept clarity. So I try my level best to give a complete crystal clear picture for you guys today. So those who are joining me first time, let me quickly introduce me and my team. I am Dr. Munjal. I am hemato-oncologist and bone marrow transplant fellow. So I have a keep deep academic interest and practicing hematologist for more than 20 years now. And we have excellent team of Dr. Aarti, consultant pediatrician, Dr. Mehdi, Ankit, Shikha, as well as Dr. Ankit, Dr. Deepali. She is a consultant gynecologist. Dr. Meghna is also there in our team. Dr. Sonal, who is like our emergency physician, Dr. Pooja, who is going to start the exclusive dental program and homeopath as well. This is our details. This is our popular book, right? This is PROMETRIC 1000 MCQ book. Keep updating this regularly interval so those who are like fond of book hard copy they can go through it. We provide the data flow services exclusive. And as I told you, I mean we have many discounted offers which include 60-70 percentage of discount as well. So those who are interested, they can go through it later on. And last but not the least, before starting, this is the key to success. Those who are like preparing sincerely, this is our channel, Medical MCQ for All, right? And we have uploaded, fortunately, hundreds of videos, right? Fortunately, it is a free access for some time, so you can get the maximum benefit of it, right? And we have excellent videos. Even if I can recommend you strongly, if you see one video a day, almost your 50 MCQs are done every day, just seeing the one video. It is meant in that way. So let's start without wasting the time. So endocrinology, first question in front of your screen. I would like to be more interactive. So first question in front of your screen, diabetic patient comes with diabetic ketoacidosis. DKA, what is the most common cause? Options are diet mismanagement, insulin mismanagement, stress, none of the above. So you think of the answer and meanwhile I want to know the answers as well. So in one question we probably solve 8 to 10 question. How to diagnose DKA? How you make a severity of DKA? What is the treatment and how you differentiate type 1 from type 2? These are the very high yield important questions. So if we solve this, almost we solve many questions in one question. Yes, so those who shy, you can post your answer in the chat box. We have facility for the chat box. So yes, Lalita. So if you can interact with me, how you diagnose diabetic ketoacidosis? Is there any international criteria by which you know that okay, fine, this is the international criteria to diagnose the diabetic ketoacidosis? Yes, Lalita. Anyone? I mean, those who are putting the answer in the chat box, I'm asking them. So it is a very basic questions. How you diagnose diabetic ketoacidosis? What are the diagnostic criteria for diabetic ketoacidosis?
The ketone body in the urine, sir.
Yeah. So tell me exactly what are the criteria. So I'll write down whatever you say. I will write down in here side by side. Yes, tell me how you diagnose diabetic ketoacidosis. That is the first question. So you need to diagnose when patient comes to the emergency room with DKA. How you supposed to confirm that this is DKA? Yes, please.
The first of all, the urine ketone bodies.
Urine ketone body. So this is only one criteria, urine ketone body, because urine ketone
No,
body is also positive in a fasting patient. Patient is who is long fasting, right? Fat gets degenerated and they gets ketone in the urine. So this is the only criteria. Yes, Dr.
no,
So
sir.
Poonam
the pa-
Rani, any comment,
so the
Dr.
patient will be having Kussmaul's
Okay.
breathing,
Sorry, what
fruity smell
patient
odor,
having? Okay,
Kussmaul's
so
breathing,
which breathing?
Bre- uh, uh, Kussmaul's breathing, sir.
Kusumal's breathing. So what do you mean by Kusumal breathing? How you diagnose crucial breathing from other bronchial breathing, bronchovascular breathing? How you define or how you see by inspection that okay, patient has a kusumal breathing, so he has a diabetic ketoacidosis. Do you know what is the
Um,
kusumal breathing or where you see the kusumal breathing or what do you mean by kusumal breathing? Yeah, you go ahead. It's absolutely an
mm.
interactive platform, so don't worry, right or wrong. You just speak up. It's a learning. Whatever
So
you are
patient
telling me,
will
I'm
be
asking.
having
Yes,
The
yes, go ahead.
electrolytes.
Let her finish one service. Sorry to excuse me. Let her finish the Hindu, then I'll get back to you. I'm not in hurry at all. We'll take 2 hours class, 3 hours class. Don't worry. Yes, doctor. Tell me, Hindu.
so,
What is the kusumal breathing?
so the carbon dioxide is washed out, so it has to be expelled also. That's why because patient will be in metabolic acidosis in ketoacidosis. Patient will be in metabolic acidosis condition along with
Fine. So this is the diagnostic criteria. So if you do not have the kusumal breathing, it is not
uh,
a diabetic ketoacidosis. Some patient does not have kusumal breathing. Kusumal breathing
uh,
absent. That does not mean it does not have or it is mandatory to have kusumal breathing.
okay.
No,
So
no, I'm just
patient will have
asking.
fruity
Some
smell odor.
patient comes to you with a 500 of sugar, right? Ketone body is present in the urine. And if you do
Okay.
the arterial blood gas and pH is showing 7.25, right? Patient has no kusumal breathing. So does this patient has a diabetic ketoacidosis or kusumal breathing is mandatory to have it?
No, sir. Patient is having diabetic ketoacidosis with or without Kussmaul's breathing. Yes.
Okay, so it can be possible without bleeding. So your homework today is to find out what is exactly the Kuzumal building common causes, right? So for
Okay.
your kind knowledge, the common causes of Kuzumal breathing, not just the decay, decay is one of them, another is renal failure, and third thing is a metabolic acidosis, severe metabolic acidosis. These are the three common reasons where you used to see the Kusumal breathing. So Kusumal breathing is not only seen in the diabetic ketoacidosis, but it could be seen in renal failure and metabolic acidosis. But what is a Kusumal breathing? How it produce? What is the clinical things, right? How the breathing pattern, like deep labored rapid breathing. So you need to know the details about the kusumal breathing. So now let's get back to again the primary question: how to diagnose diabetic ketoacidosis? So kusumal breathing may be present, it could be absent. That means it is not much good diagnostic criteria, right? If some patient doesn't have kusumal breathing, that does not mean that patient does not have DKA. So what is the definition? I think it's a very simple and basic things, right?
Diabetic
I think,
glucose level is more than 400 mg per diem.
okay. So first criteria is glucose level is more than
So
100, 200, 300, 400, 500,
fo-
400
500.
400 400 mg per
What
diem.
whatever you say, I will write down. Then I'll share you the complete where you guys are doing mistake in basic thing. DK diagnosis, DK is a basic thing, right? I'm not going much in detail, but I will go. Okay, so one is a 400 sugar. That's it. Only one criteria. If somebody present to you with a 450 sugar, is he in a diabetic ketoacidosis? Sorry, one criteria is glucose. What else criteria? Speak up fast.
ketone bodies.
Ketones body is positive.
Ketone body. Okay, ketone bodies. Where? Blood, serum, urine, or both? Or either
Both.
of this? Both. So somebody does not have one right in urine. It does not mean. Does it mean that he has no diabetic ketoacidosis? Fair enough. You go and review the literature. I'll tell you. So these are the two criteria, or any other criteria for diabetic ketoacidosis? Three, four, five. Any other things missing?
pH of less than 1.2, acidosis.
Acidosis. So third point is acidosis. Okay, fine. So acidosis means how you define acidosis in DKA. What test you do to confirm the acidosis?
pH value, ABG.
pH value. How you do pH value is by doing ABG. ABG stands for arterial blood gas. So how much is the pH, right? Normal pH by my knowledge is 7.35 to 7.45, right? In a normal individual. So what is the pH supposed to be here in DKA?
Less than
Less
7.35.
Less than 7.35. Fair enough. So it's a acidosis more than that. So let's jump to the basic definition, right? So I think we struggled a lot to just get a basic definition of DKA, right? So for the sake of the answer here, those who had given the wrong answer, diabetic patient comes with the DKA. What is the most common cause, right? So diet mismanagement, yes, but it is not as common as the insulin mismanagement. So this is a second number. This is also second number stress. The number one cause global is insulin mismanagement. So answer for this question is insulin mismanagement. Now we are seeing the diabetic ketoacidosis. How we supposed to diagnose the diabetic ketoacidosis? So let's go to the proper literature. Whatever I'm telling, absolutely literature, 100%. The most common cause of DKA is given option diabetic insulin mismanagement. In practice, leading trigger of DKA is inadequate insulin or missed dose or incorrect administration of the insulin. Right. Other major causes include infection. Right, but it is option is listed here. So infection is the second other cause common. Right, but the as per the option here, the most important is the insulin mismanagement, right? So what is the things, the most common cause of DK is the missed insulin. So you are not going, say for example, patient is diabetic, right? Type 1 diabetes especially, right? Missing, right? He is not taking before breakfast, lunch, he missed somehow, right? So missed insulin, or if he took it but not took it properly, or dose is inadequate. So inadequate insulin, right? How they can take inadequate, skipping the insulin, wrong insulin dose, right? Faulty insulin pump, poor compliance, right? Blah blah blah. So these are the most common things which we come across. So what about the stress? Stress includes surgical stress, trauma, infection, all can cause stress, and it releases the right, but not as common as insulin omission. So insulin omission, one of the most number one cause of diabetic ketoacidosis. Along with that, the second number is infection, trauma, surgery is also a major cause. So two cause you need to remember in your practice while anybody coming to you in the emergency room with DKA, insulin mismanagement, and never ever miss the infection. Never ever miss the infection, right? So you sometimes have seen many patients, those who are diabetic uncontrolled before surgery, they stop the oral hypoglycemic and put it on the insulin. Why? Because they need to have a good sugar control. If the sugar is very high, they may go into the DKA. That is why peri-operatively most of the physician, surgeon, all they put them on the insulin. This is the reason why, right? So let's go to the real picture of DKA. So what is DKA? You don't need to mug up. Those who mug up, they have a hard time. So there are three words: diabetic ketoacidosis, diabetes. So simple definition of diabetes: blood glucose level of more than 200. Somebody told me 400. It is absolutely wrong. So keep now anything more than 250 blood sugar coming into the emergency room. 1D stand after D, ketosis. So ketosis, what ketosis is K? Either ketones in the blood or the serum or urine, right? Either positive serum or urine. You don't need both this or this. And what kind of, do you know the name of the ketones? It is beta hydroxybutyrate. If somebody asks you what, so you ask for the report serum beta hydroxybutyrate. If it is positive in blood or urine, it's fine. So D and K is done, and after D, K and A stands for acidosis. So acidosis, right? 7.35 to 7.45 is a normal range. So we have acidosis. Anything less than 7.35, here the 30 is acidosis. So you don't need to mug up. This is the DKA. You should have diabetes, you have ketosis, you have acidosis. That's it. So you don't need to have kusumal breathing, this breathing, that breathing, blah, blah, blah. Right? If it is there, fine. If it is not there, fine. So if you have this criteria, that means it is diabetic acidosis. I think I'm very much crystal clear from my side. Is that clear to you, everyone? Yes or no? At least tell
Yes,
me yes
sir.
or no.
Yes, sir.
Yes,
Yes, sir.
sir.
Very,
Yes, sir.
very clear cut, transparent definition. Let's jump to the basic how you differentiate type 1 and type 2. Still, people are struggling, especially medicos. What is type 1, type 2? So, this is the most simplest summary table for you guys. I got it. Cause autoimmune. Type 1 is autoimmune, no insulin, right? So, they're kind of some kind of antibody against isolate beta Langerhans cells, right? So some kind of antibody which kills all the cells in the tail of the pancreas, and there is zero insulin, no insulin, right? So no insulin, right? Absolutely. So what is the treatment when there is no insulin? Treatment is only insulin. There is no oral hypoglycemic in type 1, right? Because what? It will not going to release anything from anywhere, right? When there is a no insulin, you must have to supplement the insulin. That's it. So here autoimmune, this is a insulin resistant. Here, if you see the serum insulin level is either normal or high. Let me tell you, either normal or high. but whatever the insulin there in the body, it does not allow, right, the glucose to get into the cell, and there is a hyperglycemia. So it's a big difference. Here insulin deficiency, right, and here the insulin resistance. So by me, diabetes mellitus is not a problem of glucose, it's a problem of insulin. Why? Because if you have insulin absent, it is type 1. If the insulin is present but it is resistant, it is type 2. That's it. This is the most simplest definition, right? So diabetes is not a problem of glucose, it's a problem of insulin. Because of insulin problem, you get a hyperglycemia, and we call it as a diabetes. That's it. So cause is autoimmune, here is insulin resistant. Usually they present early in the life, right? They are young. They are older, usually after 40s, 50s, right? You especially in the obese patient, obese patient. So we'll see the patient body type. So body type is what? Lean and thin, lean and thin. Here often overweight, metabolic syndrome, overweight, obese, insulin level very low or zero or absent. And here normal or high, normal or high. Insulin is there, but it is not utilizing well. That's the problem in type 2. Treatment here, no insulin, supplement the insulin. There is no other options globally. Type 1, only treatment world over is insulin, right? Lifelong. Where, how, lifelong. Here lifestyle changes, right? Because resistance, insulin resistance. So causes of insulin resistance, you must go and read it. One of them is obesity. One of them is obesity. One of them is high calorie or high sugar intake. That is all comes under lifestyle. So you, if you change the lifestyle, you probably control the type 2 diabetes, right? Oral medication, that is called OHA, oral hypoglycemic agent like metformin, sulfonylurea, vildagliptin, DDP4 inhibitor. There are a lot of things we'll see sometime. And last but not the least, insulin, obviously. So insulin is also right. But nowadays the oral hypoglycemic are so well that with oral hypoglycemic you can control 5 years, 10 years, 20 years. When all oral hypoglycemic exhausted, last resort for type 2 is the insulin, right? But here day one, insulin. Diabetic ketoacidosis risk is high because, right, this type 1 they have a, right, absence of insulin, absence of insulin. So they have high sugar, they are more high risk than the type 2 diabetes mellitus, right? They also have high risk, right? I mean they also can get. So it's not like type 1 only get DK can get by type 1, type 2, but more incidence prevalence is in type 1 because of insulin mismanagement. They are not taking insulin, sugar is high, right? So in absence of sugar to the cell, they convert this all fat into, they break down the fat, eventually beta-hydroxybutyric acid, acidotic breathing, acidosis, patient rapid breathing, comes into the emergency with high-grade fever, right? Tachycardia, perspiration, then patient has excessive urination, dehydration, kusumal breathing, but it may or may not present. So every time they just have, right, sometimes acidotic breathing. So you can, if you can see like orange breathing, like if you put a nose around the patient's mouth, you can feel like orange smell, right? So it's a thing, and it's a weak genetic in this correlation here, the strong. So grandfather has a diabetes, his son has a diabetes, son of the son has diabetes, his son also has diabetes. That is type 2. That is type 2, right? So this is what the thing is. So this is not shell, right? This is a basic understanding of type 1, type 2 versus type 2 diabetes, which you must know it. You must know it 100%, right? So let's go to the basic question. So how to diagnose DK? We have three word: diabetes more than 250, ketosis, presence of serum and urine ketone, or an acidosis 7.35 or less each, right? So we have seen the how to diagnose DK, how to differentiate 1 and 2, severity of decay. So I would like to know from any one volunteer how you supposed to diagnose. I mean, so once you diagnose the decay, so your diagnosis is done decay. Okay, fine. Sir, I have for 250 sugar. Patient has ketone in the urine, serum on urine, and is acidotic. So DKA is done. So is there any criteria? This is mild decay. This is moderate decay. This is severe decay. And if it is there or not. Number one question is what I am writing is present or absent. Such thing is existing in the world or not. If at all, yes. How you say, sir, this is mild, this is moderate, this is severe? Yes, anyone. If it is there. If no, you can answer. There is no nothing like this, sir. Yes, please. Yes, anyone. Fine. Anyone wants to try, doctor? Fine. So if you don't want to try, I will tell you the truth. Yes, somebody is trying. Deepika, if you want to try, you can try, because once you try, you never ever forget. That is for sure.
there is the criteria mild, moderate, severe,
Wonderful,
and
brilliant.
it depends upon like
Yeah, so
the
it's in front
consciousness
of
of
your
the
screen. Yes, so it's in front of your screen. pH and HCO3. So mild, right? So before mild, you need to know what is normal. So I told you, already told you normal. Normal is 7.35 to 7.45 is the normal, right? And here more than 18 to 20 or 24 something is normal bicarb, right? This is pH means acidosis. If it is there, normal. If it is mild, right, from 30 to 25, 5 points, right? Then 24 to this 7 and less than 7 is severe. Here less than 10 is severe. So any patient comes to you with the 250 sugar, ketones in serum or urine, acidosis, and it falls under this, this is the worst prognosis. So you just need to see pH, you need to see it. pH 7 less than 7, bicarb is less. That's it. So soda bicarb is another the most important prognostic factor. Let me tell you, they ask in the exam, prognostic factor, right?
Coco. No.
Which depends the mortality as well. So bad the bicarb, bad the acidosis, patient has high risk of death. So you need to do the pH in all the patient and get to see what is pH, what is bicarb. That's it. So this is what about the severity. You must know it, right? You must know it because this is one of the most commonest emergency globally because every house has a one patient of diabetic ketoacidosis. And let me ask you the management last but not the least. So can anyone tell me what are the steps of treatments or management of decay, right? Organically. So you need to treat a patient who has a diabetic ketoacidosis. It is confirmed case of decay now, right? So patient you want to treat, how you supposed to start? One, two, three, four, five. Any steps are there? Or randomly you can first give antibiotic, then IV fluid, then sugar management, or there is no protocol? If at all there is a protocol, let me know. Obviously,
First
ABC is
IV
there. In any
fluids.
emergency, ABC is there. So this is basic for airway breathing circulation. That is taken care of. Now, what is the next? Yes, Sahila, would like to
So
make any comment?
first we have to give IV fluid resuscitation, sir.
Wonderful. IV fluid is the number one. What else? You
Yeah.
had given the IV fluid to the patient. What else you will do? Next step.
Next we'll
insulin.
start with insulin correction, point 1 units per hour.
Sorry. I'm missing your point. Sorry. What next step?
Point 1 units per hour, sir.
Okay,
Insulin
so
infusion.
insulin, basically insulin. You can start insulin.
Yeah.
Okay, fine. What else?
And then we have to correct the electrolyte imbalances. If there is any hyperkalemia or hypokalemia, we
So
have to start the
electrolyte
correction.
imbalance, you have to do it. Okay. What else?
Yeah. Underlying sepsis, we have to give antibiotics, sir.
Under to underlying sepsis or infections or leukocytosis, blah blah. So you
Yeah.
told absolutely perfect step, absolutely perfect step. There is no mismatch, absolutely brilliant. So this is what the thing is, right? So this is the management. So let me put it on the paper nicely, just to have a better
Yes.
understanding how we supposed to treat. So first
Yeah.
and foremost, after ABC is taken care of, management, airway, breathing, circulation for any emergency globally. First, fluid, right? Cornerstone is fluid. So how, which fluid? Again, there is a question, which fluid you start? So start with the, which is compatible with the body. Normal saline 0.9%, right? Or NS, normal saline. Restore perfusion and correct dehydration. These patients are dehydrated. They are passing urine very much, right? So they are keep urinating polyuria, polydipsia, polyuria, polydipsia. So polyuria, urine is gone out of the body, fluid is gone, so they are dehydrated. Give the first and foremost thing is IV fluid. You cannot replace this with any treatment, believe me. So whenever patient comes to the emergency, you feel this is non-diabetes, type 1, type 2, infection, whatever, blah, blah, take ABG, right? Look at the parameters, vitals, start the normal saline, right? You check the glucose, you send for the this blood and serum ketones, and you go for the ABG. So within 10 minutes, you can diagnose DKA. Meanwhile, you start on the suspicious, you can start this without anything. There is no harm giving NS to any patient, right? So you start it. Then second is a insulin, right? Because insulin is the only thing which makes this diabetic ketoacidosis under control. So when glucose is under control, right? When you give the insulin, it reduces the sugar and it suppresses the ketosis as well. So this is cornerstone of the treatment after IV fluid, as you rightly said. Second, third is electrolyte, especially the potassium, because potassium, right? What happens when you give, say for example, this is a serum, this is serum, This is cell. What happens when you give the insulin, right? When you give the insulin, what happens? The glucose from the serum, that is hyperglycemia, goes into the cell. So sugar level will down into the serum. But what happens? Not only sugar will go inside the cell, along with the sugar, potassium is also go. So when you give the insulin, there are two problem happens. One is hypoglycemia can happen, another is hypokalemia can happen. Because glucose is going into the cell, potassium is going into the cell. That is why you need a potassium replacement. So you need to keep a watch on the potassium, right? Every 1 hourly while you are giving intravenous insulin, right? And treat the trigger. There are many triggers. Commonest trigger is infection, antibiotic, especially when patient has a history of fever, patient has a leukocytosis, patient has neutropenia, or patient has a history of sepsis, or patient has obvious infections or wound infection. In that case, you have to trigger, because this is insulin mismanagement is number one cause. Second is a stress. The most important stress is the infection, right? So missed insulin, you educate at the time of discharge, right? And at the time of, these are the three, MI and stroke. This is again a stress. This is again a stress. So in stress, the sugar will increase. So treat the trigger. So you need to treat the underlying causes as well, right? So that's it. And complication, if you don't treat it, cerebral edema, ARDS, hypokalemia because of insulin, hypoglycemia, right? Because of insulin. So hypoglycemia and hypokalemia both can happen. ARDS is cause of death. Cerebral edema is cause of death. Acute kidney injury, right? So these are the all strong complications of not treating the DKA, right? So preventions, right? You just need to educate the people about diabetes, diabetes management, insulin management, or how you can avoid the insulin mismanagement, and that is how you can save the life or prevent the complications. So that's all from my side for DKA. I think I tried to touch all the important high yield parts of the DKA. Is that clear to everyone? Yes or no? So that is what we started with. So in one question, we solved a lot of question in one question. Dr. Saila, is that clear to you?
Yes, sir.
Yes, sir. Yes, sir. Yes, sir.
Wonderful, brilliant. So let's jump to the next question, which is easy, but again 10 question. We see at least 20 MCQ will solve in short one-liner question. 20 MCQ minimum in this question. Drug of choice for hypertension in diabetic patient. Drug of choice for hypertension in diabetic patient. Beta blocker, diuretic, ACE inhibitor, calcium channel blocker. Second question. You need to
Sir,
know choice of antihypertensive in various comorbidities. Yeah. So first of all, answer this, then we'll jump to the next.
AC inhibitor, sir.
Yes, Miss.
Wonderful, brilliant. AC inhibitor. Now, lots of questions will arise. So, diabetes is there. Diabetic patient develop hypertension, right? So, drug of choice for hypertension in diabetic patients. So, patient was already diabetic, but now he developed the hypertension. So, you told AC inhibitor. Second question. Here, the diabetes will remain the same. Diabetes mellitus plus asthma. Diabetes mellitus plus ischemic heart disease. Diabetes mellitus plus gout. Diabetes mellitus, right, plus stroke. Diabetes mellitus plus dyslipidemia. Diabetes mellitus plus benign prostatic hyperplasia. Diabetic mellitus plus acute myocardial infarctions. These all are the questions. Any volunteer who can answer me all the question, please? Because they can ask you anything. They can ask you drug of choice, right? Question is that drug of choice for newly developed asthma in diabetic, drug of choice for severe uncontrolled hyperuricemia in diabetic, drug of choice for developing bad benign prostatic hyperplasia, right, in diabetic. So think over it. I'll get back to you 1 minute. Yes, any volunteer wants to try this? Because I mean, we seen for last many years only one scenario, hypertension plus diabetic, but it is not mandatory that they ask you. So anyway, first of all, see the answer. I will answer all the 20 questions in one questions, don't worry, with the reasons, logic, and explanation. So this is the answer. Drug of choice for hypertension in diabetic is ACE inhibitor. Why ACE inhibitor? That is important, just not the answer. We need to know why ACE inhibitor, why not alpha blocker, why not beta blocker, why not calcium channel blocker. So, because the ACE inhibitor protects the kidney by reducing the intraglomerular pressure, by that it reduces the protein or proteinuria and it saves the kidney. That is the reason why we want to give it, because ACE inhibitor protects the kidney, right? It slows the progression of diabetic nephropathy and recommended a first line therapy in diabetic with or without microalbuminuria. So you don't need to confuse a patient as a microalbuminuria. So you can't give the ACE inhibitor. So if you have 1 plus microalbuminuria, it prevents from going from 1 plus to 4 plus. So even with the microalbuminuria, you can use it. If not, then it is well and good. But even if there is a microalbuminuria, you can use it, because you don't want to go that 1 plus microalbumin, 2 plus, 3 plus, 4 plus, and then eventually diabetes induced chronic renal failure. So you need to give at any stage with or without proteinuria, because it's a renoprotective drug. And that is, and all, what are the drug? We forget it, pharmacology. So all pril, prefix is pril. What pril? Captopril, captopril. Pril is there. Enalapril, enalapril, pril is there, right? Ramipril, ramipril. So pril is there, right? So this all pril is a ACE inhibitor. So this is enalapril, lisinopril, ramipril, and there is a long list. These are the common one which you know, right? So the correct answer is ACE inhibitor. Now let's jump to the our tricky questions with the various all combination, right? Somebody is thinking, why not sir beta blocker? So let's see that as well, because our job is not just to get the answer, but why other options are not there, that you have to make a practice every day, right? Then you become a master of the MCQ. So you need to know each, yeah, so you need to know the abnormal thing. So beta blocker is, why not the beta blocker? Because beta blocker masks the hypoglycemia symptoms. What exactly does it mean? What do you mean by sir hypoglycemia symptom? So when there is a hypoglycemia, patient has a sweating, patient has a tachycardia, right? Patient has a confusion, right? These are the symptoms of hypoglycemia. But what happens when you give the beta blocker in diabetic patient? These all symptoms gets masked. It can mask. Means you does not have tachycardia, you does not have sweating. So anybody saying, oh, this is fine, there is no hypoglycemia, right? So it's a misleading, right? So you should have some symptoms. If patient has acute myocardial infarction and chest pain, even layman can also diagnose. But you have silent MI, acute myocardial infarction with no chest pain, then it is difficult for you. Then your expertise will come into the picture. Though there is a no chest pain, this patient could have acute myocardial infarction considering oil high risk features. Same things applies here. So it's try to avoid, because it masks the hypoglycemia symptoms in diabetic, right? Especially the tachycardia, because beta blocker, right, reduces the pulse, it causes the bradycardia, right? So tachycardia is missed. May worsen insulin resistance. This is another disadvantage, right? So one, you mask the
404
hypoglycemia,
floor.
you worsen the
Sister
insulin
Janiki.
resistance. Can you please close your mic, doctor, if you're not interacting with me? I'll mute it all. You can unmute later on. So may worsen the insulin resistance, used only if the specific situation such as post MI, heart failure, angina. Why? Because there is some kind of survival advantage, right? So beta blocker is the only drug which has all property. Antihypertensive, you can use labetalol, yes, right? Anti-arrhythmic, you can use in flutter fibrillation, yes. Can you use this in a arrhythmias? Yes. So this all can be prevented by only drug which is beta blocker, and that is why it has some role. So use only if there is a specific indication such as post MI, right? Because it reduces the oxygen demand of the heart, and that is why it is has a role. Heart failure, yes, and angina, right? So these are the advantage, but in general it is avoided. In general, just simply the diabetic, it's avoided. And other options as well you need to know, right? Why? So beta blocker we have seen, right? The drug of choice is ACE inhibitor, so beta blocker is avoided. We know now, clear, crystal clear, right? Now again we are thinking, sir, why diuretic cannot be used as a first line? So why not used as a first line diuretic? Thiazide can increase glucose level, and we don't want to increase glucose level in diabetic patient, and that is why it is not used. Number one, most important, and may worsen like beta blocker insulin resistance. So these are the strong indication of not using the diuretic in diabetic patient. And calcium channel blocker, why we cannot use it? Right. So when they control the blood pressure, they control the blood pressure in diabetic, but not provide the renal protection. Renal protection is provided by the ACE inhibitor, right? ACE inhibitor is a renoprotective. It reduces the intraglomerular pressure. It reduces the proteinuria. It saves the kidney, and that is why it is most important. So calcium channel blocker and say for example ACE inhibitor both can reduce the blood pressure, but it is not a renoprotective. It is renoprotective. So that is the reason why we need to use it, right? So that's it. This is what the our all the things that what we are discussing, why this not. So concluding our talk, why this is the drug of choice for diabetes, this uh, hypertension in diabetes. So provide the base renal protection, right? It slow the progression of microalbuminuria, eventually nephropathy or diabetic nephropathy, and strong data recommendation by American Diabetic Association, JNC guideline, and many international guidelines. So concluding our talk, the ACE inhibitor is the first choice of treatment for this hypertension in diabetes, right? Now let's come to all our next 20 questions. What are that 20 questions? Right? So let's see what are the antihypertensive drug of choice when there is a comorbidity. It's extremely important and it's a day-to-day problem. So tomorrow you may have patient diabetes with asthma, diabetes with hyperglycemia, diabetes with BPH, diabetes with proteinuria. So how and what you supposed to use as per the guideline? So first we have seen diabetes with proteinuria, with or without proteinuria, ACE inhibitor. Why? Again, which drug and why it is used? Renoprotective, reduce progression of nephropathy. Strong recommendation. Diabetes, no proteinuria, again ACE inhibitor. Chronic kidney disease, again. So something wrong with the kidney in diabetes. The bottom line is that ACE inhibitor is a drug of choice. Simple. Let's come to little more tricky things related with the heart. So when there is a diabetes is common, diabetes, this is all we are talking about. Comorbidities means along with the diabetes, comorbidity. So along with the diabetes with the kidney disease, diabetes with ischemic heart disease. Now here the beta blocker is the first choice. Beta blocker, proven mortality reduction, proven. So right. So overall reduction of the death is increased if you use or add the beta blocker in ischemic heart disease. So somebody is asking you diabetes mellitus plus ischemic heart disease. What is the treatment of choice? Use the beta blocker, right? Post MI, beta blocker plus ACE inhibitor. Heart failure, ACE inhibitor, ARB, right? Beta blocker like carvedilol, metoprolol, right? So these are the drugs. So anything goes wrong with that, right? Add the beta blocker, right? Atrial fibrillation, rate control, you can use the beta blocker, right? Because you want to control the rate. So this is first drug, right? We have seen the first drug. What is the drug of choice? Right here, again, a little list. Black patient. Many times they say black African male presented with hypertension, blah, blah, blah. What you supposed to use? Calcium channel blocker or thiazide. No ACE inhibitor, no beta blocker. Just for your knowledge. See, so this is a little tricky. Black patient, African Caribbean, right? ACE inhibitor is less effective as monotherapy. So calcium channel blocker, if does not control, add thiazide diuretic, right? Pregnant patient, pregnancy with diabetes mellitus plus hypertension in pregnancy, all antihypertensive drug you can use labetalol, pregnancy beta blocker, methyl dopamine, mild to moderate case, right? Benign prostatic hyperplasia plus hypertension, alpha blocker, prazosin, tamsulosin, it improves the urinary symptoms. So in BPH, what happens? BPH patient, right? So patient has already hypertension. He develop BPH or BPH patient develop hypertension. So you need to relieve the BPH symptoms, you need to relieve the blood pressure. So this is the drug which controls the both the thing. It not just reduce the blood pressure, but it also improves the urinary. So this is drug of choice, 100%. Nothing, no ACE inhibitor, no beta blocker, no calcium channel blocker, only alpha blocker. Migraine beta blocker, hyperthyroidism beta blocker, osteoporosis drug of choice, right? So hypertensive patient develop the osteoporosis. What is the drug of choice? Thiazide. Why? There is again no ACE inhibitor, no beta blocker, no calcium channel blocker, only thiazide. Why? Because it reduces the urinary calcium loss. because osteoporosis where your bone matrix is reduced, right? So this is the only drug which reduces the calcium loss, right? You want to prevent the calcium loss, so this is a reasonably good drug of choice. Essential tremor propranolol, pheochromocytoma, tumor of the suprarenal gland or adrenal gland, alpha blocker first, right? Phenoxybenzamine, then beta blocker. So this is a important. It's a question. So every one liner is a question in exam. Raynaud's phenomenon with hypertension, calcium channel blocker. Why? It does the vasodilatation, improve the flow of the blood. It reduces the blood pressure as well as is improve the blood flow to the fingers, to the peripheral things. Raynaud's symptoms can be reduced. Chronic liver disease, very interesting. Chronic liver disease patient develop hypertension. What is the drug of choice? ACE inhibitor, ARD are avoided if advanced cirrhosis. Otherwise, you can use this, right? In that case, you can prefer beta blocker calcium and gout hyperuricemia. Avoid thiazide. Why you want to avoid thiazide? Because it worsen the hyperuricemia. So here osteoporosis, thiazide is drug of choice. In gout, it is avoided. Why? Because it increase. So right. So it reduces the calcium loss, but same time it increases the uric acid level in the serum. And that is why gout already hyperuricemia. You are giving thiazide. It reduces the renal excretion of uric acid and it worsens the gout, and that is why it is not a treatment of choice. So this is all complex combination of all the hypertension with various condition, with diabetes, heart disease, liver disease, kidney disease, stroke, blah blah blah, right? So this all you must know it. It is not just you know need to know only the diabetes and hypertension. So that's it from my side. I think we covered a lot of questions in one liner. So I think it's all pretty much clear from my side. Is that clear to everyone? Yes or no? Dr. Rabia, is
What
that
about
clear to you?
asthma,
Yes or
doctor?
yes, please.
What about asthma with diabetes and
Yes, sir,
hypertension?
clear. It's a very good summary.
Wonderful, brilliant. Yes, so that is your homework, doctor. Otherwise, you will not read. Anyone wants to comment on this? What Dr. Sahila asked the question? Hypertension with bronchial asthma. What is the drug of choice? Go and read it. Otherwise, you guys will not read it. If you can't find out, drop me a message in the evening. I will give you the all explanation on your WhatsApp. This is my direct number. Those who did not saved it for any help. I get back to you as soon as possible. Great. Right.
Okay,
So
sir.
this is what I would like to open up your mind. Our preparation should not be monotonous. Our preparation should be up to the mark. And if you go by this way, it's just the two simple slides. See, I did little exercise. I mean, this is not in the book. I mean, where you can get it's not spoon feed like that, right? You open up the book. I prepare whole the week to make this PowerPoint super brilliant. Believe me, I give my 100% for every Sunday class. 100%, right? I should not feel whether you enjoyed or not enjoyed, I don't know, but I always enjoy my class myself. Why? Because I feel that I give my 100% input to the class, right? I tried my level best to explain each and everything. What comes into the exam, I provided you. So this is how you have to do. Otherwise, it's a one line and anybody can present this, right? But it takes a lot of time, effort, and energy to prepare this because it is not given in all book. Even it's not in MTB2, blah blah blah. You open up, nothing detail like this is given, right? It's chapter wise, but we need to compile under one platform. So that's all anyway. So let's jump to the next question. Your homework, I feel those who respect me or my lecture, they will send me the message by evening or by tomorrow is cutoff line in next 24 hours on my this WhatsApp. What is the treatment of choice or antihypertensive in asthma? This is on mobile, this is on WhatsApp, this is on bottom, wherever you feel comfortable, you can send me. So I feel that you respect me. Anyway, everybody is respecting, but I want you to make little more active, right? Preparation should be up to the mark. So you received a call from a father who has son diagnosed with type 1 diabetes mellitus for 6 months. He said that he found his son lying down unconscious in his bedroom. What you will tell him if he is seeking for advice? So you get a call. I'm in the emergency room. I'm an emergency physician. I got a call from a father whose son who recently diagnosed type 1 diabetes, and he's saying me, sir, my son is lying down on the floor. He is unconscious. What I supposed to do? What you supposed to do, right? You have four options. What is the best option for him for now? Bring him as soon as possible to here. So you tell them, okay, I can't do anything. You bring it to the hospital by ambulance, right? Or you call ambulance. You call You do not call anyone, you directly call our ambulance. Third is give him a usual dose of insulin, right? Patient has hyperglycemia or something, diabetes, you give insulin, you don't need to ask anyone. And you give intramuscular glucagon. So what you supposed to do, first of all, what you supposed to do? What is the diagnosis? So those who are joining me first time, let me tell you, this is the brilliant triad I created. This is MCQ, any MCQ. So this is MCQ, multiple, right? This is question. Amongst this question, this is multiple choice. So this is MC and this is Q. This is question multiple choice. So this is cumulatively MCQ, right? You need to know three things in each and every MCQ: diagnosis, investigation, and treatment. That's it. So if you cultivate the practice of doing this practice in each and every MCQ, I am guaranteeing you get 90% plus score in any exam. Forget about pass. 500% pass, 90% plus you will get it. When you ask three questions to yourself, what is the diagnosis of this scenario? How I supposed to investigate this patient? How I treat this patient? Three questions, that's it. Yes, anyone, now go to the question. What you supposed to do in such scenario?
Give a
Hypoglycemia, sir.
clean glucagon.
Fine. So one answer is Dr. Deepika is glucagon. I'll make a list of the answer, right? What the audience is saying me, right? So don't go on the anybody's answer. You give your own answer because nobody will come to guide you in examination hall. Whatever you feel, you give the answer. Somebody has given the answer that may not be right. So don't get biased, I mean to say.
Diagnosis is hypoglycemia.
Diagnosis is hypoglycemia. Okay, fine.
Investigation is blood sugar.
Okay, so tried one thing you solved, Dr. Sandhya, is hypoglycemia. Diagnosis is done. How you supposed to investigate? You do the random blood sugar probably, right? So now the
Yes.
question comes, what is the treatment?
Glucagon.
I am
Okay, so your answer is glucagon. Okay, fine. Anyone else? Fine. So let me ask
Sir,
you, Dr.
agree,
Sandhya, if you don't, sorry, yes, yes,
agreed
yes,
with
Rabi.
Sandhya. Sir, agreed with
Sorry,
Sandhya.
sorry, Dr. Rabi, I'm not getting your answer.
Sir, I'm agree with Sandhya.
Oh, sorry. Okay, you are agree with Dr. Sandhya. Fair enough. So, Dr. Sandhya, if you can open up your mic, tell me what is a glucagon
Sir,
first of all. Yes, what is a
it's a show
glucagon,
that
Dr. Sandhya? Do you know what is glucagon?
Yes, sir.
Yes, Dr. Sandhya. If you don't know, that's fine. You can say no, I don't know. Anyone wants to comment, Dr. Rabia? What is a glucagon basically?
It will raise the sugar levels, or it will be secreted by
It
pancreas, which
raises the
will increase
sugar
sugar level
level.
of the patient.
Okay, fine. So from where it does get released? Where is located this
Pancreas.
glucagon?
It is
From the pancreas.
alpha 6.
Pancreas.
Pancreas. Which
It's
part
a
of pancreas?
hormone.
Pancreas.
Islets.
Pancreas has a head, pancreas has a body, pancreas has a duct, and pancreas has a tail. So from where exactly this glucagon comes from? Sorry to ask you anatomy, physiology, biology at the same time.
from liver, I think.
Liver. So liver. Fine. So glucagon is released from liver.
Pancreas. From
Okay, fine.
pancreas.
So second homework. Second homework for whole the class. We are close to 30 doctors now who joining. I can see it. So your homework is to just get the basic information about the glucagon. Just do some exercise. Fair enough.
Alpha
So
cells
what?
of the pancreas.
Okay, so let's see. So why you don't want to call the ambulance? Why you don't want to, right, rush to the emergency room? Why you don't want to
Sir,
rush?
Sir, one
glucagon is
question here. So can it be due to decay also? If it's a type 1.
That we'll discuss. So whether it is a decay, this patient is suffering from decay, or this patient is suffering from hypoglycemia. Now you tell me what is
Sir,
how,
if
right?
there is
Because
a de
how you
if
sir,
there is
differentiate?
a de
sir, glucagon
So
is
I
the
think
counter-regulatory hormone
we
when glucose
One
level
minute.
drops.
Let's
cannot do
okay.
anything.
1 minute. Dr. Kings, you finish it. We'll discuss. I'm not in hurry at
We
all. Dr.
will
Kings,
have
let finish Dr.
to
Kings.
rush
Yes.
the
Yes, sir. Please.
ER
Your voice is, sir, breaking. Sorry to say that, but I cannot hear you well. Probably check your mic or system ecosystem. Right now, second candidate. How you know that this is hypoglycemia or DKA? Tell me. It's important discussion, na, because patient is unconscious. It could be
is
diabetic
there
ketoacidosis unconscious. It could be a severe hypoglycemic unconscious, right? Because they have said, sir, unconscious. So unconsciousness
No,
can
sir,
develop here.
I
Unconsciousness
was
can develop here.
saying that
Fruity order.
uh,
So
Sir,
no.
there should be this short history of
because
shortage.
it's unclear the information.
I'm sorry to say again once again your voice is not clear. It's very much
The breath
breakdown.
of the patient.
Hmm.
Bring him as soon as possible.
Simple. Remember one clue and tips and tricks from my side. If something is not mentioned in scenario, something is
Then
not mentioned in the scenario means it is not there. Means it is not there. Is that clear? So here the
yes,
vitals is not mentioned. Here vitals not mentioned in the scenario. Considered vitals is normal.
wrong.
Considered vitals is normal. They had not mentioned about kusumal breathing, increased respiratory rate. Considered it is normal. They
So
had
I
not
think it will
mentioned about the
depend on the most
CBC,
common
WBC.
cause of unconsciousness in type 1 diabetes.
So what do you think? If
Which is
patient has
hypoglycemia.
type 1 diabetes mellitus
It,
patient, what is the commonest cause? Is it decay or hypoglycemia? Number one.
Hypoglycemia.
Hypoglycemia.
Hypoglycemia, obviously
Hypoglycemia.
hypoglycemia. So hypoglycemia is the cause here. And now you want to, what is the logic? So first, one thing we concluded, sir, and it is recently, I mean, right? They say type 1 diabetes, clear cut, right? So type
Yes,
1
sir.
diabetes, right, when comes to the unconscious, until proved otherwise, first diagnosis is hypoglycemia. Number one. Number two, you hypoglycemia means low glucose. You want to increase the glucose as fast as possible to prevent the brain injury. Number one. And only
Hmm.
thing, right? Calling to ER will not increase the sugar. Calling ambulance will not increase the sugar. Right? Giving insulin, you are dying. You are making him to die. Right? Because insulin already hypoglycemia, you are giving him usual
Yes.
dose of insulin. So this is absolutely a crazy thing. What can increase the glucose is IM glucagon. That's it.
Ugh.
Just for your knowledge, those patients who are diagnosed with type 1, they have given the very well education, right? What is type 1 diabetes mellitus, what to do, how to take insulin. If you miss the insulin dose, what to do. If patient is unconscious, what to do. They had given one kit. In this kit, there is a glucagon is there. Is that clear to everyone? Yes or no?
Yes, sir.
Yes.
Sir, one more doubt.
Yes.
Generally, in India, we advise them to take some peppermint or something. So, if
Wonderful,
like
brilliant. So
there's
excellent
an
answer.
instant glucose.
Excellent answer. So we will not give that. Only one reason. Do you think patient can take peppermint when they are unconscious?
No, no,
No.
no, or not.
No,
If there is decay, he must be short of breath before unconsciousness.
possible, but it is not mentioned there. And anyway,
Yeah.
So, what would be the scenario if this was a DKA case?
right? So in decay, usually they must have given the scenario that patient has a history of fever, patient has a kusumal breathing, patient has increased respiratory rate, patient has a acidotic breathing, ABG was done, pH was 7 less than 7.3, blah blah blah. Right? So they
Sir,
never
or
confuse in the exam.
okay.
Believe me, they never confuse in the exam. And biggest complication of diabetes on insulin, until proved otherwise, you must not miss the hypoglycemia globally. Globally, any diabetic patient. That is why history is important. Na? When some patient comes to the emergency room, you must see take the vitals. In my there are vitals is what? Don't take it otherwise. Every temperature, pulse, BP, respiratory rate, and SpO2. This is general vitals. I added three things in my emergency room. Though I'm not a cardiac physician, I'm a hemato-oncologist. But whenever sister comes to me, I added three things. One thing, I added random blood sugar in the emergency room. I added the pain score, and with the risk factor, irrespective of the complaint, I'll supposed to do the ECG. These three things I added in vitals in my emergency room because sometimes chest pain is not there. Chest pain is not there. Patient comes with some vague complaint. I have chest uneasiness. I have a gabraman. I mean, very, very irrelevant. But he has hypertension. He has diabetes. He is smoker. He is obese. He has strong family history, but no chest pain. And because of no chest pain, I'm not taking the ECG. And next 10 minutes is in the VTVF and he will die in front of you because of cardiac arrest. That's it. So this is what I created. You probably create in your emergency room. So this is absolutely mandatory. International in every guideline, this is vitals. But I added these three things in my vitals for my patients, right? So it's a simple test. Not doing RBS is simple test. If patient is unconscious, right? Nobody with him, somebody else brought him, right? He was running in the garden. He is suddenly unconscious. Somebody's got, he doesn't know. Stranger doesn't know he has diabetes or not diabetes. But checking RBS, I see, oh, sugar is 40. Go and give the dextrose 25%. Within 10 minutes, he is conscious. That's it, simple. So you need to see the complete scenario, what exactly they are saying, and that is what you should have high level of suspicious. So any diabetic, whether type 1 or 2, until proved otherwise, something goes wrong, rule out hypoglycemia. That's it. This is bottom line. Then whatever you want to do, you do in your emergency room, whatever. So answer is give him IM glucagon. The question describe type 1 diabetes child, right? So type 1 is usually in the child, early age group, thin and lean, right? Insulin is the only treatment. He found unconsciousness at the home. Unconscious at home is likely due to severe hypoglycemia. First action at home is to give the intramuscular glucagon, right? And child is unconscious, that is why he cannot take oral glucose. As somebody told me, sir, why not peppermint, why not glucose? Unconscious patient cannot take anything orally, and it's not good idea. Risk of aspiration if you force that people, right? So if conscious, if say for example this patient is conscious, I probably go with the oral, right? I probably go with the oral, but it's unconscious. Clear cut scenario. There is no confusion in the scenario. Glucagon rapidly increases the blood glucose by stimulating the hepatic glucogenolysis, right? And this is the recommended home emergency treatment for hypoglycemic patient. And after giving the glucagon, what would be the next step? Then you call the ambulance, they call this, that, that's fine, no problem. But first of all, first you give, because they may come in 5 minutes, right? Probably don't take it otherwise. But in India, probably there are 150 billion people. Ambulance may come on time, not on time, whatever, I don't know, right? So they usually come on time. They usually come on time, but it takes 5 minutes. Patient is living on the 10th floor, 12th floor. Accessible is different. So this is a lot of logistic while transporting the patient. So wise thing is to give the glucagon first. After that, bring him as soon as possible to ER, because if, right, so if ER comes to your home, it's difficult. But for you to reach to ER, it's easy, right? So bring him as soon as possible to ER. Call ambulance and give him, right, giving him, why not this is the option, right? Our option was give glucagon. Four option. Somebody saying, sir, why not ER? It is too slow. The child may suffer brain injury, because long hypoglycemia, long brain injury, right? First correct the glucagon immediately, then you do, right? Call the ambulance. Yes, you can call the ambulance, but after giving the glucagon, give him the usual dose of, it is extremely crazy things, extreme dangerous, because already hypoglycemia, insulin will further damage the brain. So summary, unconscious type 1 child, treat as a severe hypoglycemia by giving intramuscular glucagon. Then call the ambulance. Don't first call and waste the time. First give the glucagon. That's it. Wonderful. So this is what the thing is. Insulin versus glucagon, right? Very quick in 15 seconds. Insulin is released or produced by beta cell of pancreas. This is alpha cell of pancreas, glucagon. Main function is to reduce the blood glucose. Here the main function of glucagon is to increase the blood sugar level. That is what the question was. Glucagon increase the glucose, reduce the hypoglycemia, right? When it is released, insulin released after meal, and this release not after meal, it released during fasting. During stress, glucose will increase, and when there is hypoglycemia, it increase. These are the condition, very important. Effect on muscle, it increase glucose uptake, no major effect on muscle. Effect on fat, increase fat storage, it increased fat storage, right? Insulin. And it increase lipolysis, breakdown of lipids. Effect on ketone, it reduces the ketone, and that is why it is the treatment of choice in diabetic ketoacidosis, because in diabetic ketoacidosis, ketone increase. Who will reduce the ketone? Insulin. So effect on ketones, reduce ketosis, this is increase ketosis, right? Reverse in general, right? Because it's treat the hyperglycemia and decay, it treats the severe hypoglycemia. Route is sub-Q, IV, basal bolus, IM, sub-Q, IV, emergency, right? So if you don't know the IV, right, they usually teach you for the IM glucagon. Side effect, hypoglycemia, weight gain, here the nausea, vomiting, blah, blah. And here the hypoglycemia side effect, here hyperglycemia. So if you overdose the glucagon, they become hyperglycemic. That's all from my side. Is that clear? I think it's transparent now, isn't it? Yes or no? At least tell me yes or no. So what is
Yes.
the glitch or what is the trick to remember? This is how insulin means in means it pushes the glucose inside the cell. In means insulin. In means so insulin push the glucose inside the cell. So insulin means inside the cell it push. Glucagon, right? It's reverse. Glucagon. Gone means gone. Makes glucose when it is gone. So when the glucagon form, when the glucose is gone, when glucose is low, glucagon increase. So that's it from my side. This is a trick to remember. If you remember, well and good. Otherwise, you can remember by some other way. That's it. Let's jump to the next questions. Hopefully, I am clear. Is that clear? Is all clear? Any confusion, any comment? I mean, it's appreciated. If you have not agreed, you can stop me. Don't worry. You can stop me anytime, sir. This is
All
not. I'm
clear,
not
all
agreed.
clear, all clear, sir.
Wonderful, wonderful, brilliant. Which of the following indicates osteoporosis? 10 questions will solve in this number 4. We solve 10 question in this slide. Though it is a one-liner, but 10 question will solve. Which of the following indicates osteoporosis? Equal T score and Z score. T score is 2 plus 5 plus 2.5. T score is less than minus 2.5. Z score of plus 2.5. T score of minus 1 to minus 2.5. Right? Another question. So this is one question. Second question, base test to diagnose osteoporosis. Third, what is the difference between T score and Z score? 4, right? How you calculate T score, how you calculate Z score. Two more question. How you differentiate one from other, and last but not the least, how you treat the osteoporosis in a normal individual or just postmenopausal woman. How you treat? Yes, a lot of questions with this. Yeah, so you anybody can comment now.
T score less
Any
than
question can
minus
come.
2.5 is osteoporosis.
So
Best
your
way to
answer would
diagnose
be C score. I mean, answer would be
T
C.
score. Yes.
This is your answer, Dr. Deepika.
Yes, sir.
Wonderful. Fair enough. So now tell me, what is the normal? What is the osteopenia? Osteopenia. It's a different than osteoporosis. Then
Minus 1 to
osteoporosis.
minus 2.5 is osteopenia. Anything less than minus 2.5 is osteoporosis. And 0 to minus 1 is normal.
Fair enough. So this is normal is anything more than 0 to minus 1 to minus 2.5 is osteopenia, and anything less than or equal to minus 2.5 is osteoporosis. So we are talking about osteoporosis. So this is the answer, T score, right? Now, doctor, can you tell me what is the T score and what is the Z score? Have you heard of the Z score in osteoporosis? And
Yes.
so this is T score, right? This classification by T score. So do you know what is a Z score? What is the classification? Is it the same as this or something
No,
else?
sir.
How you differentiate this from this?
Uh,
Anyone?
demography is also added. Like,
Yes, Deepika. Do you know what is a Z score? First, tell me what is Z score, how you calculate the Z score, which is the age group where you compare the Z score, or what is the interpretation of the Z score? When you say it is a mild, moderate, or severe on Z score, lot of question. Is that it? Yes or no? They probably ask you Z score as well. No? I'm asking you T score. You are comfortable, but T score. But they will not ask as per my class. They will ask anything, and that is why I'm teaching you all the things, not one thing. Fine.
The
Anyone
Z
wants to
score is
comment? Yes, yes. Go ahead, doctor. Go ahead.
uh,
I'm very happy you are interacting. Yes,
okay.
go ahead.
The Z score is the T score that is adjusted for age and the gender of the patient.
So, can you give me the example? Say, for example, I want to uh, take my Z score, Dr. Munjal's Z score. How you do it? Speak up, whatever. I mean, Khadija, yeah, please.
Uh, I'm not very sure on that, sir. I just know the value.
Fair enough, fair enough. I'm happy. At least you are interacting with me. I'm very glad. No worries. So this is learning platform. This is my job to make you think out of the box. and only lecture can make you out of the box, not just simple reading. So the answer is T score of less than 2.5. What is the WHO criteria? Will do with all literature, specific literature, nothing, just all WHO standard guideline. So anything more than minus 1.5 mine is normal, right? Minus 1.5 to minus 2.5 is osteopenia. Osteoporosis is less than or equal to minus 2.5. And when you have minus 2.5 plus fracture is severe osteoporosis. So T score of minus 2.5 with fracture, severe osteoporosis. Right. So that's it. So this is one answer. It's clear now, right? Is that clear to Dr. Khadija, to you? Is that okay with you?
Sir.
Wonderful. So this is simple definition, but you need to remember. So T score of minus 1 or more is normal. T score of minus 1 to minus 2.5 is osteopenia. Anything less than 2.5 is osteoporosis and severe with the fracture. Right. So now this is second chart. Right. Why other options are not the correct answer. So what was our question? Which of the following indicates osteoporosis? Answer is C. T score of less than 2.5. Here T score of less than 2.5, it's qualified. So answer is C. Let's see why not other options. That is also important, and that is the most important thing which you need to know in your day-to-day MCQ preparation. Diagnosis, investigation, treatment. So equal T score and Z score is not the diagnosis. T score of 2 plus point is normal. Z score of 2.5 suggests secondary cause, not the osteoporosis. T score of minus 1 to 2.5 is osteoporosis, osteopenia, not the osteoporosis. So what is the fittest answer is the osteoporosis is C. Now let's see, I put some these things in your mind about T score and Z score. So how to differentiate T score? Usually young adult comparison, used Dr. Khadija for diagnosing adult more than 50. T score usually adult more than 50, right? How they compare, T score is compared with a young adult comparison, right? And who is the object, who is the patient? So our father, our mother who is more than 50, example, right? And you want to know the T score, they will compare with the young adult and then score, see, minus 1 or minus 1, 0, sorry, this is out, this is 0, right? Here you go minus 1, minus 2.5, here anything more 3.5, here plus 1, here plus 2.5, plus 3.5, like that, just for understanding. So 0 to minus 1 is normal, minus 1 to minus 2.5 is osteopenia, and anything more than 2.5 minus is osteoporosis. Is that clear? Yes or no? And this
Yes, sir.
compared with the patient, with the patient, with the young adult, with the young adult. And what happens in the Z score? The same age comparison, 50 years compared with 50 years, 60 years compared with 60 years, right? 75 years compared with 75. That is Z score. Is that clear? Yes or no? Yes or no?
Yes, sir.
Yes or no?
Yes, sir.
Wonderful. Again, the summary table for T score and Z score, you need to know, right? So here T score, as I told you, they compared with the young adult, they compared with the age match, same age, 50, 50, 60, 60. Here, if the patient is 65 years, but they compare with the young adult of 35 or 30. Here, if the patient 65, compared with 65. Here the patient is 65 but compared with 35. So young adult, right? Used to diagnose osteoporosis, yes. It is used, no. Used for what? To whom? Especially used for post-menopausal women, because they are the people, right? So say for example, our mother is more than 50 usually. If our age is more than 20, then our mother must be more than 50 now, and we are not 20, we are at least 25 because we finished the graduation, medical graduation, so we are at least 25, mother is 50. So do go and check your mother's T score, go and do the DEXA scan. What is the investigation of the choice? Best investigation amongst all is the DEXA scan, right? Used for children and younger adult, not for the postmenopausal woman. Threshold concern is minus 2.5 or less is osteoporosis, minus or equal to evaluate secondary causes, right? So that's it. This is what the thing is. So this is mainly the main score is used for osteoporosis is T score. So last slide for T score. So I already told you, explained you in a simpler schematic presentation. This is the 0, this is baseline. Green is good, green means good to go. So anything 0 to minus 1.5 is normal. Minus 1 to minus 2.5, here is 2.5, is osteopenia. Anything more than minus 2.5 is osteoporosis. So osteoporosis range, osteopenia range, all normal range. That's it. That's it. Is that clear to everyone? Yes or no?
Yes, sir.
Wonderful. So for the sake of the answer, the T score of more than or this 2.5. So anything above 2.5 is this, right? Jump to the next question. Your homework. What is the treatment of osteoporosis?
Yes, for sure.
Tried, right? So go ahead. We'll discuss diagnosis of osteoporosis done by the T score. How you check the T score by DEXA scan. How you investigation is again DEXA scan. How you supposed to treat? Go and read it. We have one questions for it as well, so we probably cover in that part, but just go and see it in detail. They probably ask you. So most common cause of hyperparathyroidism, sorry, iatrogenic medullary carcinoma of thyroid, parathyroid adenoma, parathyroid hyperplasia, parathyroid carcinoma. Just for your clarity, I bring this picture to you because many people doesn't know where is the parathyroid gland. So this is a thyroid gland, right lobe and left lobe of thyroid. I'm drawing with a red line. There are two pairs. This is pair 1 and this is pair 2. So there are two pair, or total number is 4. So there are 4 number, or if you can say pair. So this is 1 pair, this is 2 pair. So 4 parathyroid number gland, they are just behind the thyroid gland, right? They are behind the thyroid gland, right? So this is a cartilage, this is a trachea. You can see the tracheal rings here. You can see the vessels, everything. So this is neck. This is again a trachea. Behind trachea, there is esophagus. This is airway. So it is situated just in front of your neck, right? Thyroid, and just behind the thyroid there are two pairs of parathyroid. This is anatomy. So now what they are asking, most common cause of parathyroidism, hyperparathyroidism, is what? Iatrogenic medullary carcinoma of thyroid, parathyroid adenoma, parathyroid hyperplasia, parathyroid carcinoma. Go ahead. Go ahead. Yes, anyone? These all are the absolutely high yield questions asked several times in DHA, HAD, and all other.
Is it
Yes.
adenoma?
Okay. I'm waiting for another answer. So your answer is adenoma, that is parathyroid adenoma, right? So what do you mean by Dr. Purnima, adenoma and hyperplasia? What's the difference between parathyroid adenoma, parathyroid hyperplasia, and parathyroid carcinoma? Why carcinoma? Carcinoma does not cause hyperparathyroidism because of tumor, swelling, malignant tumor.
We were talking about the most common cause, so that's why it can also
Fair enough.
cause.
You can stick to your answer. I may confuse you. Don't worry. Do you know how much is the chances? So if there is a problem, so hyperparathyroidism. Can you classify the hyperparathyroidism
Primary and secondary.
classification? Primary and secondary. If I can say there is a tertiary is also there. Are you agreed with me or not?
Yes, sir.
Fine. So what is the difference between primary, secondary, and tertiary? Tell me. So primary here I write down here PTH, growth hormone, and I write down here calcium. So
Calcium.
what happened in primary? First of all, what happened in primary?
Particular to the
First to
organ,
PTH.
like parathyroid.
Yeah, so what happens? Say for example, I just simple question, forget about this. I say there is a
Alpha.
you are suspecting any patient has hyperparathyroidism. So what labs you are expecting in primary? So what expect PTH normal increase or decrease, calcium normal increase or decrease. That is what I want to ask. And what is secondary?
Can I speak?
Yes, anybody can speak. It is
Yeah,
open
sir.
platform.
In primary, PTH is also increased and calcium is also increased,
Okay.
I think.
So how you differentiate from secondary? Here both the decrease?
Sir, I think one is decrease, one is
Which
normal.
one is decrease? Which one
I
is decrease?
forgot.
Sir, in
One is
Thyroid hormone is increased, but calcium can remain normal also, as it is
wonderful.
compensated.
So first of all, clarify the concept. Don't mug up. Clarify the concept. In secondary hyperparathyroidism, what happens to PTH? First question.
PTH is increased
Okay,
because
fine. Increase. And calcium,
it can be normal or less.
normal or less. Second question. Every answer has a question. So why less? Why less? What goes wrong in secondary that calcium is less? What is the most commonest cause of secondary hyperparathyroidism? Most common cause of secondary hyperparathyroidism.
The vitamin D,
hypercalcemia disease.
vitamin D deficiency most common seen.
It is
Let's see what other comments come. So one comment
Chronic
is
kidney
secondary
disease.
hyperparathyroidism. One comment is chronic kidney disease. So vitamin D deficiency, one comment, one is chronic kidney disease.
chronic.
Anything else? Anything else?
Calcium
Sorry?
deficiencies. Calcium deficiency.
Calcium deficiency is because of what? What goes wrong in secondary hyperparathyroidism that the calcium deficiency will develop? Are you getting my question?
Yes, sir.
Yes, tell me. So what is the cause? Fair enough. I'll tell you. I will I will open up all my trump card. Don't worry. I'm very well prepared before any class. Don't worry. So most common cause of hyperparathyroidism is primary, right? So primary, we are talking about primary. So you need to know most common cause for primary, most common cause of secondary, most common cause of tertiary. So three question is there. We are talking about primary. So 85% is due to single parathyroid adenoma, the most common. That is the answer, right? So parathyroid adenoma. So let me tell you, this is a thyroid. Behind thyroid, there are four pairs, right? So one of them, right, single parathyroid adenoma. So there is a tumor in the adenoma. This is benign tumor. This is benign tumor. 85% of the thyroid. So when there is a problem primarily in parathyroid, it is called primary. So primary problem is in parathyroid gland. That is why the name comes primary hypothyroidism, secondary hypothyroidism, tertiary hypothyroidism, right? The hypothyroidism is common. So whenever the word comes hyperparathyroidism, basic I'm going to give you. Hyperparathyroidism means parathyroid hormone is high in all three, whether it is primary, secondary, tertiary. Primary hyperparathyroidism, secondary hypoparathyroidism, tertiary hypoparathyroidism. So hyperparathyroidism means PTH is until proved otherwise high. Is that clear to everyone? Whatever the
Yes, sir.
change is happens, it happens in different level. We'll see that as well. Concept clarity. So it is a benign condition. It is benign, not a malignant. So 85%, right, is due to single parathyroid adenoma. Other causes could be parathyroid hyperplasia, that is also in option, but just 10% to 15%. So this is second most commonest cause. If somebody say after parathyroid adenoma, what is the second most commonest cause of hyperparathyroidism? It's a parathyroid hyperplasia. How you differentiate parathyroid hyperplasia? Here just tumor. Here the parathyroid itself become enlarged. There is no tumor per se, it is enlarged, right? So it is hyperparathyroid, this hyperplasia, like benign prostatic hyperplasia, right? Like parathyroid hyperplasia, uterine hyperplasia. So hyperplasia, hyper means high and plasia means formation. So per se parathyroid gland in general as a whole enlarged, while in parathyroid adenoma gland would be remain the same, it will not enlarge, right? But there is a tumor in the parathyroid. That's it. This is difference. So size is normal, but tumor is there. Here no tumor, but size is increased. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes, sir.
Right. Third is a parathyroid carcinoma less than 1%. So if you see 100 patients in a year, only one patient has a cancer. That is parathyroid carcinoma. 85% has this. Iatrogenic usual causes hypoparathyroidism, not hyper. Iatrogenic usually, right? So what is the commonest complication of total thyroidectomy? When they remove thyroid, there's many a times removed this parathyroid as well, right? So patient usually present with hypokalemia. Biggest complication of this medullary carcinoma of thyroid causes calcitonin increase, but not increase in PTH, right? So this is not the answer. So we had explained and dissected each and everything in this. Let's go to the primary, secondary, tertiary, which looks very, very tricky to everyone, right? So if you don't remember tertiary, it's fine. Don't get confused. If you don't remember tertiary, fine. Primary problem is in parathyroid. Secondary problem is not in the parathyroid, problem is in the kidney. Problem is in the kidney. So primary and secondary, what happens? So here they have not mentioned, but if I can write down, calcium is increased and PTH is
PTH.
also increased. Primary. Here the difference is hyperparathyroidism means PTH is increased na? Everywhere. Primary, secondary, tertiary, PTH would increase. Here PTH increase. Here PTH increase. What changes in the calcium? So just remember primary, secondary, calcium is high, calcium is low. Why? Because of chronic kidney disease. There is no problem in the parathyroid, problem in the kidney. So what happens because of the kidney? Right? So kidney is losing more calcium. So parathyroid keep increasing to make the normal calcium level, but it is losing from the kidney. So primary, here the parathyroid problem, here the kidney problem. That's it, if you remember. So primary, both the things are high calcium, high growth hormone. That's it. So this is what the primary, and I have a lots of discussion with this, and I have a lot of this chart with this. This is exhaustive chart of primary, secondary, and tertiary. I don't want to scare you by showing this chart, but just I'll go through it quickly. I'll go through it quickly. Primary problem is in the parathyroid. Commonest 85% cause is adenoma. Most commonest cause, second most common cause is hyperplasia, and less than 1%. Third is carcinoma. We have seen it already. Secondary, chronic hypocalcemia due to chronic kidney disease. So problem in this in the kidney, right? And it is excreting calcium. So chronic hypocalcemia, and because of chronic hypocalcemia, what, right? What the kidney is losing the calcium. So parathyroid feels that there is a no calcium. Let me make a lot of calcium. So parathyroid is increased, but calcium is losing from the kidney. Second cause is vitamin D. In absence of vitamin D, calcium cannot be absorbed. So hypocalcemia eventually do the secondary hypoparathyroidism, and same malabsorption. Calcium you are eating, but it is not getting absorbed, right? So PTH will be increased, but calcium is low. So that's it. This is how PTH, as I told you, it increase in all condition. PTH high, PTH high, PTH high. That is why it is primary, secondary, tertiary hyperparathyroidism. So it's a basic definition. Here the calcium is high, secondary calcium is low. Phosphate, here the reverse low, phosphate is high. Vitamin D is normal or low. Here the vitamin D deficiency is very common. Here usually normal, because it is nothing to do with the vitamin. Here it is with the parathyroid adenoma. So if I get a parathyroid adenoma, my vitamin D is normal. That's it. Typical patient, middle-aged woman with kidney stone and bone pain, right? Here the typical is vitamin D deficiency and CKD. So patient is on dialysis. All patients on dialysis. You go and check the parathyroid. You go and check the vitamin D and calcium. You can find out it is a secondary hyperparathyroidism, right? Here the feedback mechanism is lost. Here feedback mechanism is not lost, right? And treatment is surgical removal the adenoma. Why? Because 85% cause is adenoma. So you just remove the adenoma. That's it. Here you don't need to remove the adenoma in the parathyroid, because problem is not in the parathyroid, problem in the kidney. So treat the chronic kidney disease. If the patient has vitamin D deficiency, give the full dose of 60,000 unit once a week for 8 to 12 weeks of vitamin D. That's it. This is what the thing is. Is that clear to everyone? Yes or no?
Yes, sir.
Wonderful. So this looks exhaustive slide, but I love it. It brings lots of concept clarity in our mind, how we supposed to treat it. So let's jump to the next more couple of questions. Single thyroid nodule shows high iodine uptake. What is the best treatment? So this is the question, right? This is our primary question. But as we, I create a lot of question in one question, right? So this is a question. This is multiple choice and lot more question. How to differentiate hot nodule from cold nodule? How to approach the thyroid nodule, right? So first of all, we go to our basic question. single thyroid nodule showed high iodine uptake. What is the best treatment? Are you going to give radioiodine 131? Are you send him home? Don't worry, it's fine. You start with the anti-thyroid medication, or you do the excision or surgery if the thyroid nodule is present or palpable. Yes,
radioiodine 131.
I want to know the why. Okay, so your answer is radioiodine. Why this is the
Because there's
answer?
already high iodine uptake, so this radioiodine also will be uptaken specifically, and which will also decrease the abnormal cells.
Okay, so high iodine uptake, right? So how did you get to know? Is there any test by you know that okay, iodine uptake is high, low, or normal? Any name of the test?
It is CT, but
Technetium 99.
Sorry, which modality? By X-ray you know, by CT by you know, by angiogram you know, by MRI you know, by PET CT scan you know. How did you get to know, or what is the name of the test which says that okay, this is high iodine uptake, this is normal, this is low? Anyway, yes, please. Anyone?
Technetium 99 scan.
Sorry, answer please. Anyone? We are close to now. Exact 29 doctors are joining me.
Radioiodide uptake scan. There is a test, radioiodide uptake scan.
What
Technetium
is the name
99
of the
scan.
test? Sorry.
Technetium 99 scan.
So why you are not going to give the radioiodine scan? Why technetium 99? What technetium 99 will do? So this is homework. You go and read it. Fair enough. Second question. Ask me someone hot nodule versus cold nodule. I will clarify each and everything. Anyone have idea that this is by size I can say, by shape I can say, by symptoms or sign I can say, by scan I can say, right? By the activity I can say. How you supposed to differentiate hot nodule? How you supposed to? We have read hundreds of time hot nodule, cold nodule. What happens to TSH here? What happens to T3, T4, TSH here? Right? How the sonography or ultrasound neck looks here? How the ultrasound looks here? It is which is more dangerous, hot or cold? Lots of question. Which has high potential to develop in a cancer? High, hot or cold? Hundreds of questions, isn't it? Yes or no? At least tell me yes or no. Yes or no?
Yes, sir. You are
Yes,
right.
sir.
Wonderful. Wonderful. So let's get the first time in our lifetime the clarity about hot and cold. So first of all, what is hot? What is cold? So this is the most high yield slide for you guys. It's not in the book, believe me. You need to do exercise from the lot of journal. So key difference, hot and cold. So hot, why hot uptake is high, cold uptake is low. Appearance on scan, bright, very bright. It is very dark, very dark. Functions, hyper functioning. Hot means hyper, cold non functioning. TSH low. Here TSH never ever low, either normal or high. So you can remember high. Here the low, TSH low. Right? Symptoms of hyper means hot means hyper. Hot means hyper functioning. Hyper functioning means hyperthyroidism. So all symptoms of hyperthyroidism. Cold, right? Uptake is low, right? It is non-functioning, right? TSH is high, right? Usually asymptomatic. Cold is asymptomatic, and that is not a good thing. Malignancy risk less than 1%. You can see here 15 times higher. What is the conclusion? Cold nodule is not good for the body or thyroid. So if somebody presented with the cold nodule, it has high malignant potential, malignancy risk. See, less than 1%, almost 99% will not develop. Here 15% will develop. Very risky. FNS is not required. Why? Because hot nodule is hyperfunctioning, hyperthyroidism. Usually you don't need it. You treat the hyperthyroidism here required to rule out the malignancy, and base treatment radio iodine 131, because your thyroid is functioning very very high. How you can reduce the thyroid hyperfunctioning? Giving the radio iodine 131 will be taken up by the thyroid follicle, and it kills the thyroid follicle. It keeps the hyperthyroid under control here based on the FNAC. high malignant potential. So depends on that how you supposed to treat. One liner word shortcut. If you don't remember the whole exhaustive slide, two line will give you the clear idea. Hot nodule, hyperfunctioning, hyperthyroid, harmless, high uptake, treat with radioactive iodine. Cold nodule, cancer, cold, considered carcinoma, FNSE. Depend on FNSE treatment. Is that clear to everyone, gentlemen and ladies?
Yes, sir.
Yes, sir.
Yes, sir.
Excellent.
Wonderful.
Yes.
So don't forget this because they will give you the exam the clue. 54-year male, female presented with this, they evaluated this, found cold nodule. Once you see the cold nodule, now your eyes would be pop up. Your mind would be pop up very high, right?
Yes.
High alert. Cold nodule, high alert. That's it, right? So it's a high malignant potential. So very important. Just jump back to the question. Single thyroid nodule shows high iodine uptake. What is the best treatment? We have already seen it. Radio iodine. So, right. So let's see why this not. That is important. Single thyroid nodule with high iodine uptake. The best treatment. That is what they are asking. So best treatment of hot nodule is high iodine, radio iodine uptake. It is autonomously functioning, hot nodule autonomously without any control. It is called autonomous. It is cold nodule is malignant, not the hot nodule. Less than 1% has malignant potential, so almost nil. It is almost always benign, right? So you don't need to operate, cause suppress TSH, right? And do not require FNSE, right? Why? Because they does not have malignant risk. Less than 1% is almost nothing. Base treatment is radio active iodine 131. That's it. That will kills the thyroid follicle and reduces the hyperfunctionality of the thyroid. That is why it is given, right? So why radioiodine 131? So it selectively destroy the hyperfunctioning nodule. It destroy because it is right. So hyperfunctioning, if you give radioactive iodine, it is taken up by the thyroid follicle, right? And it will kill the hyperactivity. So it selectively destroy the hyperfunctioning nodule. So if the nodule is there, right? So this radioactive is taken up by this nodule and this radioactive iodine kills this hyperfunctioning nodule. That is the mechanism of action, safest and most effective long-term treatment. So once it is killed, it's killed forever almost. So in one go, you are done. Especially preferred in an adult, toxic adenoma, multinodular goiter with toxic nodule. So key exam point, a single hot thyroid nodule, radioactive iodine 131 is the treatment of choice.
Nice.
Some people are saying, sir, why not other options? Let's discuss other options as well as usual. Send home. It is not a good idea to send home because patient is symptomatic, hyperacting. So no, not correct because hot nodules typically cause hyperthyroidism. You must treat it. You must treat it. So it's not a good idea to send home without doing nothing. Antithyroid medication is too early, can control the symptoms. Antithyroid can control the symptoms. It will not kill the hyperfunctioning nodule. So you need to do something with the nodule. So it can control antithyroid medicine, can control the symptoms, but does not cure the autonomously functioning nodule. Nodule will remain there. It just controls the T3, T4, TSH. Excision surgery second line, right? Usually used when very large nodule which cannot be destroyed by the radioactive iodine. Compressive symptoms. You have mechanical compression, huge nodules, right? Compressing trachea, compressing esophagus, compressing upper aerodigestive things. In that case, you need to do something surgically to relieve the mechanical symptoms. And you have a suspicious of malignancy, though it is very rare, less than 1% with hot nodules. So in this three case, you can go for the surgery. So obstructive symptoms or suspicious of malignancy, otherwise not. That's all from my side. So this is what the things we have seen it, right? So answer is the radioactive
Iodine 131.
131. So let's take one more questions. Probably I extend the class for next Sunday as well because this is very important the class. All right. I have many questions to discuss in a, it's a long things, right? But let's discuss one more and we'll see the next time The second, endocrinology, the remaining part. So amongst the several types, therapeutic intervention in osteoporosis, which therapy considered as a gold standard method of preventing osteoporotic fracture among postmenopausal women? So question is very transparent, crystal clear. You have a postmenopausal woman, right? She is a osteoporotic. You want to prevent the osteoporotic fracture in this postmenopausal woman, right? Let me tell you whose score is, say, for example, less than minus 2.5, right? So it's a proven case of, and you want to prevent the fracture. So amongst the several type therapeutic options, so among several type, these all are therapeutic option, right? In osteoporosis, these all are used in osteoporosis. Which therapy considered a gold standard? So amongst A, B, C, D, which is considered gold standard for what? For prevention of osteoporotic fracture in which category? Postmenopausal woman. So hormone replacement therapy, vitamin D and calcium supplement, exercise and stop smoking and stop alcohol, anabolic steroid injection would be the extremely helpful. Yes.
Sir, answer B. B.
B.
Yes. One by one. Yes.
B.
Tell me. Vitamin D and calcium. Vitamin D
Yes,
and
sir.
calcium.
Yes.
Rabia, what's your answer?
Sir, B. B is my answer. Vitamin D and calcium.
Okay, so I write down the name so I don't forget Dr. Rabia. Anyone else?
The hormone replacement therapy.
Okay, so this is Deepika. So there are two questions. Good. More options comes, more controversy comes. Is good for discussion. Yes, Dr. Purnima is A. Anyone else? There are 30 people in class. Only
A,
answer
sir.
is only
A,
two.
sir.
Okay, another is Dr. Sunil is A. Only three answer. We are 30 people. Where is 27?
Sir, B. B. B, sir.
Dr. Safa is B. Okay. Where is
B,
another
sir.
20? Last
B, sir.
question. Please interact.
B,
B,
sir.
sir.
B.
Dr.
Sir, A,
Zulekha, what's your
hormone
answer?
replacement therapy.
Dr. Asma is A. Okay. Where is the
Yes,
other
sir.
25 people?
B,
Sorry, I
sir.
want 31. Okay, another is
Vitamin
B.
D, sir.
B, sir.
Option
Yes,
B.
sir.
B.
Dr. Rizvi is vitamin D. Okay, B question. Okay, fine. Anyone else? So I remove the C
Sir,
and D.
B.
Nobody is answering
A,
C and D.
sir. A.
B, B, sir.
B, sir.
So lastly, Dr. Rabia, you convince me, right? Let's discuss now. I got it. I got the idea that okay, half audience is B, half audience is A. So Dr. Rabia, you tell me by your experience, right? What you supposed to do to prevent the osteoporosis, right, in a postmenopausal woman? Vitamin D you supposed to give to the patient? Hello,
No, sir.
Dr. Rabia. Let the Dr. Rabia to speak because she has given the answer B. So let me understand first, then we'll discuss. Yes, doctor.
Sir, if the same scenario patient come to me, I advise vitamin D and calcium because HRT has lot of other problems like
Okay,
side effects.
but fine. So,
Because
but
this
they
is
ask the gold standard method of preventing.
gold
So,
standard with prevention.
if your
They
patient has
ask
vitamin
about
D normal,
preventive method.
if your patient has
Sir, they
vitamin D
ask,
normal, and if your patient has calcium normal in postmenopausal, and you want to prevent the fracture, do you think this would be the best option?
sir, because they ask preventive is nowadays HRTs are not giving regularly because of certain side effects. So we will
So
prefer to
let
give.
me ask you, what are the side effect of hormonal replacement therapy, or I
Sir,
can say
even
estrogen replacement therapy? Tell me the biggest risk of estrogen replacement therapy in postmenopausal. If I started
it's
to my patient, okay, you take hormone replacement therapy or you start taking estrogen because your estrogen is down after postmenopausal, and that is a culprit for all the consequences. So you start with the estrogen. So what estrogen? So she get benefited in fracture. So reduce the risk of fracture significantly by supplementing the estrogen. So this is advantage, biggest advantage. This is advantage. I want to know what is the disadvantage. Why you are afraid of not giving the estrogen replacement therapy? Why you are afraid? Tell
Ovulation
me the
will
reason.
increase.
Carcinoma.
So,
Carcinoma.
sorry,
C.
Endo
Endometrium.
Endometrial carcinoma and
endometrial carcinoma.
population.
what is
Endometrial.
endometrial?
C. Endometrium.
Okay,
and
fine. CO1 got it. So endometrial carcinoma. This is the only
Thromboembol
problem. Because of this only you are worried.
thromboembolism risk, sir.
Yes,
VT,
yes.
VT is the venous thromboembolism. Second, two risk. Is there any other risk or just this is two risk? That's it. Fine. So this is also pharmacological knowledge checking, right? Fair enough. Now, can anyone tell me what is the major why this osteoporosis so fast and concern in a postmenopausal women? Because of what mechanism this happens? Osteoporosis happen because of what? Why we are not discussing every time in male? Why we are just discussing in female? Why not in male? Every platform, everywhere, female postmenopausal osteoporosis.
Because it's more common in female.
Estrogen helps
Because of
in calcium absorption.
okay, so estrogen withdrawal or estrogen is postmenopausal, your hormone level goes down. Estrogen, progesterone. So this estrogen will cause what? So your estrogen was normal in menstruation and
Decreased calcium
postmenopausal.
absorption.
Sir, it will decrease the
Decreased calcium absorption in bone.
Fine, fine. So what is the mechanism of osteoporosis? Low estrogen or low vitamin D?
Low estrogen.
Low estrogen. So by replacing the estrogen will not help the patient more.
It will.
So here, for the sake of the answer, what they are asking, right? They are asking gold standard. Gold standard method. Gold standard means the most effective. That is gold standard, right? The meaning of gold standard means most effective, and most effective is the hormone replacement therapy, right? So let's dissect why this not. All we discuss. Last question. So explanation why hormone replacement therapy is the gold standard because they are asking gold standard. So let's discuss. So in postmenopausal woman, the main cause of osteoporosis is the estrogen deficiency. So by this one line, the logic is by replacing the estrogen or estrogen replacement therapy. Estrogen is a hormone, that is why they are called it hormone replacement therapy or estrogen, same thing. So estrogen is deficiency, so you must replace. You are treating the primary pathology. Because of what osteoporosis is done, you are treating the main cause of. Vitamin D supplement is not the main cause. It will not increases the estrogen level for sure, right? So in postmenopausal women, the main cause of osteoporosis is estrogen deficiency. Estrogen replacement therapy directly counteract the bone loss and significantly reduce the vertebral fracture, hip fracture, wrist fracture, and overall risk of the fracture in the body. Because once you replace the estrogen, it goes all over the bone and it reduces the bone loss, further bone loss. And this is the most important because it treats the root cause. Vitamin D does not treat the root cause. High hormone replacement therapy is considered as the gold standard therapy for prevention of fracture in postmenopausal woman, right? So this is very important sentence when benefit outweighs the risk. So our female is fine, she has no thromboembolism, no other risk, no cardiac things, fine. In that case you must use the estrogen things, replacement therapy, right? But there are some complications as well. But for the risk of the complication, patient comes to you with the acute myocardial infarction and you are feared to give thrombolytic like streptokinase, urokinase, alteplase. Why? Because the risk says bleeding, severe bleeding, intracranial bleeding. You cannot give thrombolytic. It is not like that. You must have to give the thrombolytic, right? Otherwise, how you can make patient survive? How you can save the life without thrombolytic when you have no PCI facility in your hospital? You must have to give. So, for the sake of the complication or the fear of the complication, you cannot say that, oh, I will not treat this, right? Because thrombolytic, there is a complication, massive intracranial hemorrhage can happen, but you have to balance, you have to rule out something, right? So this is the summary table, right? So what is this advantage? We'll see the advantage and disadvantage. What we are discussing, estrogen, advantage, disadvantage, both. Relieves the vasomotor symptoms, or postmenopausal symptoms. Prevent osteoporosis, so it reduces the risk of fracture. It improves the vaginal atrophy. Patient present in postmenopausal with dryness of vagina, itching, some pain, right, or local vaginal symptoms because of estrogen deficiency. This all because of estrogen deficiency.
Mhm.
Estrogen deficiency. So once you supplement the estrogen, it relieves osteoporosis, vaginal atrophy, urinary symptoms, and it improves the quality of life in postmenopausal woman. Same way disadvantage. Every coin has a two side, right? Every coin has a good and bad. Here good and bad. Increase endometrial cancer, especially when you are using alone only estrogen replacement therapy. If you are using estrogen and progesterone replacement therapy, right, then it will not increase. But alone, if no progesterone is increased, it increases the breast cancer, it increases the deep venous thrombosis or pulmonary embolism or stroke, it increases the gallbladder malignancy, contraindicated in many conditions. So what you do supposed to do before starting the estrogen therapy, you need to ask, does any family history of breast or endometrial cancer? Does patient has past history of thromboembolism? Right. So if there is a no contraindication, otherwise patient is fine, healthy, otherwise in a good condition, you must use the estrogen replacement therapy. And along with that, whatever you want to supplement, diet, exercise, calcium, vitamin D, sunlight, lifestyle modification, all are supplementary. But the gold standard test or treatment is hormone replacement therapy. Let's dissect why not vitamin D. So it's important supportive care. It is not a causative. It will not improve the estrogen level at all. It just a support. It helps to maintain the health. It does not significantly prevent the fracture on its own. It does not. It's supportive care. If it is there, vitamin D, you supplement it, patience is there. But it not does not significantly prevent the fracture the way estrogen will do. Exercise, stopping alcohol, smoking, very important lifestyle measure, helps to prevent the loss, but not the gold standard, not the gold standard. Anabolic steroid not used for osteoporosis can worsen the health because it makes the more osteoporosis. If so, somebody is taking the anabolic steroid for bodybuilding, right, in the gym, youngsters are taking anabolic steroid, so it improves the muscle mass, but it causes the bone loss, osteoporosis, right, and completely incorrect choice. So in context with that and discussion, all the way we did it is all favoring the estrogen replacement therapy. So that's all from my side. Thank you very much for listening me coolly and calmly for 1 hour and 41 minutes. So thanks everyone. Before I end up my session, I would like to have a quick feedback. Those who joined first time, especially I don't know, there are 30 doctors, right? Or anyone. How did you enjoy? What was the concept? How you clarify your thought process by talking and interacting with me? Anyone, please just spare more 5 minutes, not more than that, please.
So it's very easy to understand your sessions because we are quite tricky. This endocrine topic is so.
What you did learn something new today?
This most regarding this hyperparathyroidism and this osteoporosis is P score and Z score. It's quite easy
And
to
you made
understand.
sure you made it easier for us by, making
To
like,
understand, yeah.
yeah, in simpler language. So that was more helpful. Like coming to, important points that we need to remember to come to the conclusion. It was
So you
actually,
overall enjoyed the lecture, learning with me. You is enjoyable things.
Yes, sir, it was a very good experience actually. It's not about the questions, it's about the concepts.
Yes,
And
that's
you are
correct.
basically working on the concepts and trying to enlighten us, tell us the concepts behind the answer. That's more important. Mugging up everything is not the key, I guess.
Good. Right. So you got some idea like how to dissect the question and how to interpret A, B,
Yes,
C, D,
sir.
E
Yes,
or
sir.
E,
Good.
or how you exclude from other. That is, try to do this practice in your day-to-day practice of solving all various MCQs of various subjects. So if you cultivate this, by my experience coaching thousands of doctors globally, I feel this would be the best secret of success by my experience. That will open up your brain. Why this not? Why this not? Why this? Why it is correct? Why this gold standard hormonal? Why not vitamin D? Or this just example, right? So we can have little more clarity in ideas. Yes. Anyone else? Something new they learned and got, or some new concept they created in their own mind for the preparation for the next, I mean, further preparation. Something helpful.
How to approach the question that
Yes,
I
sir.
really liked it, like the diagnosis, investigation, and treatment. If you just, like you say, you have to come to the conclusion of the answer from the question itself and not by going to the MCQ, like multiple
Exactly.
options.
So yeah, so once your concepts are clear, even you don't need to see the options. Whatever you are thinking, it's there in the option. You understand? But that comes from the practice, isn't it? Yes. Anyone else? Dr. Rabia, how did you enjoy this class today? Dr. Zulekha, how was your experience?
Sir, fine. Very good experience. I first time I attend the live class, so very helpful. And
Wonderful.
very much I enjoy and learn not
Wonderful.
the questions but explanations and clear concept of each topics. Thank you so much,
Wonderful.
sir.
Wonderful. Yes, Dr. Khadija, how was your experience? Helena, Ranmini.
So you explain everything very clearly. It's awesome, must say.
Yeah, I'm glad to hear that. Yeah, I will come up with the more energy in the next class, though I'm coming with energy anyway in every class. Yes, Poonam, how was your experience? Dr. Poonam, I think you joined the first time. How was your experience?
Yes, sir, I enjoyed your class. Very good, excellent.
Wonderful. So
Yeah,
what's
thank
your
you.
so try to do a preparation in organized way, not just somebody saying, sir, I solve 150 MCQ. I don't want you to solve 150 MCQ. Just solve 25, but 25 in that way it's close to 150. Right? You need to know whatever you do, you need to know each and everything. And if you don't know anything, just know the three things for one question: diagnosis, investigation, treatment. 99% of your job is done for any exam, believe me. So, anyway, thank you very much once again joining me. We'll see you in the next class with the remaining endocrinology. So, get prepared with more tricky and important questions for thyroid, for insulin, for glucose, then other things, then Cushing syndrome, Addison's disease, low dexamethasone, low dose dexamethasone scan, high dose dexamethasone scan, lots of questions, and we are always confused. I have ready, but we'll discuss the next time with all other remaining tricky topics. Thank you very much and enjoy your Sunday.
Thank you, sir. Thank you.
Take care, sir.
Thank you, sir. Thank you.
Take care.
Thank you so much, sir.
Bye. Take care.
Thank you, sir. Thank you.